You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about aortic dissection. We'll go over epidemiology, physical exam findings, imaging features, medications for initial management, and surgery and percutaneous intervention. Let's start with epidemiology. Aortic dissection has a 2-to-1 male-to-female ratio. In men, aortic dissection occurs most commonly in the 50s and 60s. In women, half of the dissections before age 40 occur during pregnancy, during the third trimester, or the early postpartum period. The presence of a bicuspid aortic valve is associated with a 5 to 18-fold increase in the risk of aortic dissection. Marfan, which is the mutation in fibrillin 1, is strongly associated in decreasing order of coincidence with aortic insufficiency and aortic root dilation, followed by aortic dissection, followed by mitral valve prolapse. Marfan syndrome accounts for 50% of aortic dissection in less than 40-year-olds. In women with Marfan syndrome who proceed with pregnancy, the expected rate of aortic dissection is 3% on average, ranging from 1% in women with aortic diameter less than 40 millimeters to as much as 10% in patients at high risk, meaning those with aortic root diameter more than 40 millimeters with rapid dilation or with previous dissection of the ascending aorta. In most women with Marfan syndrome, aortic dissection occurs in the third trimester or postpartum, although it may occur at any time. In women with Marfan syndrome wanting to get pregnant but having an aortic diameter more than 4.0 centimeters, it is reasonable to consider prophylactically replacing the aorta prior to pregnancy. Pregnancy is contraindicated in Marfan syndrome patients with a dilated aorta exceeding 4.5 centimeters. Cocaine, not heroin, use has been associated with aortic dissection. Why? Cocaine causes the walls of the coronary arteries and aorta to become thin due to smooth muscle apoptosis and cystic medial necrosis, leading to coronary dissection or aortic dissection. Let's move on to physical exam. The pain of aortic dissection is sudden in onset, severe, most intense at its inception, and is usually described as tearing or ripping in quality. The pain tends to migrate corresponding with a propagation along the aortic wall. Although patients with aortic dissection appear to be in shock, their measured blood pressure is typically elevated, especially if the dissection is in the distal rather than the proximal aorta. Unequal arterial pulsations are more common in proximal aorta dissections. New aortic regurgitation may appear if proximal aortic dissection extends to the aortic valve apparatus. Other than aortic dissection, unequal arterial pulsations in the upper extremities can also arise from Takayasu disease, subclavian artery atherosclerosis, and supravalvular aortic stenosis. This cannot occur from subvalvular or valvular aortic stenosis. In coarctation of the aorta, the coarctation is usually distal to the origin of the left subclavian artery, so it leads to higher blood pressure in the upper extremities compared to the lower extremities, but the arm pulses and pressures are usually equal. Depending on the extent of aortic involvement, patients may present with various signs and symptoms. Asymmetrical blood pressure, more than 20 millimeters of mercury between limbs, that's caused by compromise of branch artery flow. Bowel ischemia or gastrointestinal bleed, that's caused by malperfusion of the celiac or superior mesenteric artery. Dysphagia may be caused by compression of the esophagus from the aortic dissection. Dyspnea may be due to compression of the trachea or bronchus, congestive heart failure from aortic regurgitation, or cardiac tamponade. Hemoptysis is vascular rupture into the lung parenchyma. Hoarseness is compression of the recurrent laryngeal nerve. Horner syndrome involves compression of the sympathetic chain. Myocardial ischemia or myocardial infarction are when the coronary arteries become involved by dissection or compression by aneurysm. A new murmur of aortic regurgitation suggests incomplete valve closure of the aortic valve secondary to leaflet tethering by the dilated aorta, or cusp prolapse because of dissection into the aortic root. Gross hematuria or oliguria That can be due to malperfusion of one or both renal arteries. Paraplegia may be due to spinal malperfusion attributable to intercostal artery involvement. Lower extremity edema may be due to malperfusion of the iliac artery. Shock may involve cardiac tamponade, hemothorax, frank aortic rupture, acute severe aortic regurgitation, or severe myocardial ischemia. Shortness of breath can be due to pericardial effusion, congestive heart failure from acute severe aortic regurgitation, or hemothorax. Stroke symptoms can occur if the carotid or vertebral artery are involved. Superior vena cava syndrome can occur if there is compression of the superior vena cava. Syncope, consider carotid artery involvement or cardiac tamponade. Now, what is malperfusion syndrome? Clinical evidence of malperfusion syndrome are the following: cardiac, electrocardiographic changes of ischemia or infarction, troponin elevation or myocardial dysfunction; cerebral, stroke and neurologic deficits, coma and altered mental status; spinal, paraplegia; mesenteric, abdominal pain, bowel ischemia, lactic acidosis, elevation of liver function test results; renal, acute kidney injury or oliguria; extremities, loss of pulses in at least one extremity, sensory or motor dysfunction. This is a list of clinical evidence of malperfusion syndrome. Malperfusion syndrome is associated with a mortality rate of 30.5 compared with a mortality rate of only 6.2% in those without malperfusion syndrome. Mortality rate correlates with the number of branch vessels involved as well as the number of malperfused organs. What do the 2022 aortic disease guidelines say about malperfusion syndrome? In patients with acute type A aortic dissection presenting with renal, mesenteric, or lower extremity malperfusion, it is recommended to proceed to immediate operative repair of the ascending aorta. That's a Class 1 recommendation. In patients with acute type A aortic dissection presenting with clinically significant mesenteric malperfusion, such as celiac-related malperfusion or SMA malperfusion, then either immediate operative repair of the ascending aorta or immediate mesenteric revascularization via endovascular or open surgical intervention by those with this expertise before ascending aortic repair is reasonable. Class 2A. Type A aortic dissection, which involves the aortic root, has estimated mortality of 1 to 2% per hour in the first hours, summing up to 25% in the first 24 hours and 50% in the first 48 hours if without operation. Type B acute aortic dissection has lower mortality, with approximately 8% in-hospital mortality, a 92% survival rate at 30 days, and a 60 to 80% survival rate at 5 years. Partial thrombosis of the false lumen, as compared with complete patency, is a significant predictor of post-discharge mortality in patients with type B dissection, but type B aortic dissections have lower mortality overall than type A dissections. Let's go over some imaging features. The 2022 aortic guidelines say, in patients with a suspected acute aortic syndrome, CT is recommended for initial diagnostic imaging, given its wide availability, accuracy, and speed, as well as the extent of anatomic detail it provides. That's a Class 1 recommendation. In contrast to Artifact, a true dissection flap needs to be independently mobile, with constant intensity through the length of the flap and color flow that respects the boundary of the flap. While an aortic dissection has a true lumen and a false lumen, aortic intramural hematoma only has flow in the true lumen and no flow in the false lumen. Microperforation of the aortic adventitia would result in a periaortic hematoma or contained rupture. In aortic dissection, the true lumen can be distinguished from the false lumen using the following echo characteristics: prominent anterograde systolic flow in the true lumen, rapid contrast opacification in the true lumen, sluggish anterograde or retrograde flow in true lumen, or thrombus in the false lumen. In the descending thoracic aorta, actually the false lumen is usually larger than the true lumen. The false lumen flows within the tunica media, secondary to a tear in the tunica intima. The further along the dissection, the more likely that the larger lumen is the false lumen. Outer wall calcification suggests that lumen is not the true lumen. Displacement of intimal calcification to the center suggests it is a false lumen. Now let's go over medications for management. In aortic dissection, you should use a labetalol drip. You can add IV nitroprusside or nicarbitine drip if needed to reduce a heart rate to less than 60 beats per minute and systolic blood pressure to 100 to 120 beats per minute within 20 minutes. Labetalol is the favorite beta blocker choice since it is a non-selective antagonist of both alpha and beta adrenergic receptors. So it has both blood pressure lowering effects from alpha and beta blockade and reduces the force of LV contraction from beta 1 blockade, leading to lower arterial dPdt in the ascending aorta. The IV beta blocker should precede the use of a vasodilator, such as nitroprusside drip or IV, to prevent reflex tachycardia, which is bad. What do the 2022 AHA-ACC guidelines on the diagnosis and management of aortic disease say with patients for aortic dissection? Patients with acute aortic syndromes, which is their more broad umbrella term to include aortic dissection, should be treated to a systolic blood pressure of 120 millimeters of mercury, or to the lowest blood pressure that maintains adequate end organ perfusion, as well as to a target heart rate of 60 to 80 beats per minute. That is a class 1 recommendation. In patients with acute aortic syndromes, initial management should include intravenous beta blockers except in patients with contraindications, class 1. In those with contraindications or intolerance to beta blockers, initial management with an intravenous non-dihydropyridine calcium channel blocker is reasonable for heart rate control, class 2A. In patients with acute aortic syndromes, initial management should include intravenous dilators if the blood pressure is not well controlled after initiation, or intravenous beta blocker therapy, class 1. Patients with acute aortic syndrome should be treated with pain control as needed to help with hemodynamic management, class 1. Now we'll talk about surgery and percutaneous intervention. Surgery is referred to all type A aortic dissection, that's the one that involves the ascending aorta, and surgery can also be for acute type B dissection that either is complicated by retrograde extension into the ascending aorta, or with persistent or recurrent pain despite IV morphine, malperfusion, for example, syncope and limb ischemia. Or it could also be in a patient with collagen vascular disorders, such as Marfan and Ehlers-Danlos. If a patient has coarctation of the aorta, you should do a CT angiogram of the brain to screen for intracranial aneurysm, but this would not be indicated if the patient only has aortic dilation without coarctation. What does the 2022 ACC-AHA guideline on the management of the aortic disease say about surgery for type A dissection, including what to do about the root? In patients with acute type A aortic dissection and a partially dissected aortic root but no significant aortic valve leaflet pathology, aortic valve resuspension is recommended over aortic valve replacement. That's a class 1 recommendation, so it's a very strong recommendation. In patients with acute type A aortic dissection who have extensive destruction of the aortic root, a root aneurysm, or a known genetic aortic disorder, then aortic root replacement is recommended with a mechanical or biological valve conduit. That's a class 1 recommendation. In patients who are stable, valve-sparing root repair may be reasonable when performed by experienced surgeons in a multidisciplinary aortic team, class 2B. Patients with acute type A aortic dissection undergoing aortic repair and open distal anastomosis is recommended to improve survival and increase false lumen thrombosis. They also have 2 recommendations about encouraging hemi-arch repair over extensive arch repair if possible. In patients with acute type A aortic dissection without an intimal tear in the arch or significant arch aneurysm, hemi-arch repair is recommended over more extensive arch replacement. That's a class 1 recommendation. In patients with acute type A aortic dissection and a dissection flap extending through the arch into the descending thoracic aorta, an extended aortic repair with antegrade stenting of the proximal descending thoracic aorta may be considered to treat malperfusion and reduce late distal complications. Class 2B. Surgery for type A aortic dissection improves survival compared with beta blockade alone because progression of the proximal aorta dissection can compromise flow to major vessels, including the coronary arteries, rupture into the pericardium, resulting in tamponade or death, or lead to severe or equivalent aortic valvular regurgitation. According to the 2022 Aortic Disease Guidelines, in patients presenting with suspected or confirmed acute type A aortic dissection, emergency surgical consultation and evaluation and immediate surgical intervention is recommended because of the high risk of associated life-threatening complications. In patients presenting with acute type A aortic dissection who are stable enough for transfer from a low to high income volume aortic center is reasonable to improve survival, Class 2A. In patients presenting with non-hemorrhagic stroke complicated acute type A aortic dissection, surgical intervention is reasonable over medical therapy to reduce mortality and improve neurologic outcomes, Class 2A. How about percutaneous intervention? Percutaneous intervention for aortic dissection is for unstable acute type B aortic dissection, malperfusion, rapid expansion of at least 1 centimeters per year, critical diameter of at least 5.5 centimeters, refractory pain, stable type B dissection, and type B dissection with retrograde extension into the ascending aorta. The 2022 Aortic Disease Guidelines favor percutaneous intervention for acute type B aortic dissection that is unstable. In patients with acute type B aortic dissection and rupture or other complications, intervention is recommended. That's a Class 1 recommendation. In patients with rupture in the presence of suitable anatomy, endovascular stent grafting rather than open surgical repair is recommended, Class 1. In patients with other complications in the presence of surgical anatomy, the use of endovascular approaches rather than open surgical repair is reasonable, Class 2A. In patients with uncomplicated acute type B aortic dissection who have high-risk anatomic features, endovascular management may be considered. Notice that in the first point, they mentioned acute type B aortic dissection that is complicated and warranting intervention. What are the consensus features of complicated acute type B aortic dissection? Aortic rupture. This can be either free or contained, including hemothorax, increased para-aortic hematoma, or both, or mediastinal hematoma, and should be addressed very promptly. Next, branch artery occlusion and malperfusion. Complete or partial occlusion of a major branch with or without clinical evidence of ischemia is malperfusion. This includes visceral, renal, and peripheral arterial branches. Next is extension of dissection. Extension of dissection flap either distally or proximally, for example, a retrograde type A dissection. Aortic enlargement, that's progressive enlargement of the true, false, or both lumens while in the acute phase, and that may require prompt intervention. Intractable pain and uncontrolled hypertension. Now, what are high-risk features in uncomplicated acute type B aortic dissection? High-risk imaging findings are maximal aortic diameter more than 40 millimeters, false lumen diameter of more than 20 millimeters, entry tear more than 10 millimeters, entry tear and lesser curvature, increase in total aortic diameter more than 5 millimeters between serial imaging studies, bloody pleural effusion, and imaging-only evidence of malperfusion. These are high-risk imaging findings in uncomplicated acute type B aortic dissection. High-risk clinical findings are refractory hypertension despite more than 3 different classes of antihypertensive medications at maximally recommended or tolerated doses, refractory pain persisting more than 12 hours despite maximally recommended or tolerated doses, and need for readmission. And that is all we have for aortic dissection, including its epidemiology, physical exam findings, imaging findings, medications for initial management, and surgery and percutaneous repair.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.